Hi, my name is Vanessa Jackson. I'm the clinical director at Adjuvant Behavioral Health. And the idea for this recording was just sort of walk you through what is my process for SI protocol and reporting. We always get these questions, especially the very first time you're dealing with this. This is not a process I have personally become super comfortable with because I don't do it with every patient. It's the processes I do with every patient that I'm really comfortable with. This one comes and goes depending on the need of the patient, and I don't always I kind of have to work through it every time. And so I want you to understand that it's okay if every time you're doing it that you're like, why is this getting easier? Well, that's normal. As long as you're following the processes and you're completing the steps, it's okay. Anytime you don't do something frequently, it's going to feel a little bit off. And so I just wanted you to feel comfortable and understand that that's normal. So I wanted to walk you through what is my process. Let's say I have a patient coming in. Let's say I'm going to see him today at it's almost 2. So let's say 4 o'clock this afternoon. I'm going to I've already looked in their documents and I can see that they took their distress thermometer. It's an intake. So I've never met this person yet. They've only met with behavioral health at this point. And so they're coming to me and I see that they have an 8 on their distress thermometer. They're not full off. It'd be way easier if they were like a 10 or 11. I would know exactly what to do there. But they're borderline and I'm not really sure what to do. And so I'm going to preload my notes so that I feel comfortable and have everything sort of in a queue and ready for me to go. So I wanted to walk you through what that looks like and how I do that. What you do is share your entire screen so you can see everything I'm doing. I'm going to need to go in and out of several documents. Okay, so here you're looking at my client file. So I'm using Test Vanessa. And I'm going to be doing an intake note. As you can see here, I've got psychotherapy intake note. I don't really know what the diagnosis is yet, unless when that intake was done initially with behavioral health that they came up with the diagnosis, then maybe I would have one, in which case I'll see it listed in their documents. And the most the session can be is 52 minutes. I'll have to adjust this at the actual session if it's less than that, but at the moment, I'm going to put 52 minutes in. And I've already preloaded this to say 4 p.m. this afternoon because that's when the appointment is, okay? So then on the note, I'm going to do the presenting problem. What is the problem? Do I know what the problem is? If I don't, I need to wait until I meet that patient. I do not know what these are going to be until I meet with that patient and I change the things that I want to have there in terms of current mental status and what I'm viewing. Risk assessment, do they have any risk? Objective content, history of problem. You walk through all the standard things for intake that you would take. But I already know this patient is coming in to see me and they have a 7 or higher. So I can see in there they're having some suicidal thoughts, but it's passive. And I'm going, okay, this is interesting. I don't really know what I'm going to do. So the first thing I'm going to do is I'm going to build in a safety assessment just to make certain I've covered those answers. In order to do that, just go anywhere in the white field area of your intake note. You're going to do a right click. This pop-up menu occurs. You're going to hit General. Another pop-up occurs, and you're going to select Safety. What that's going to do is see how my note looks the same, nothing changed. But if I scroll to the bottom, it's added safety to the end of my assessment. And so now I can do these extra questions and it helps me understand how high level is this. And it kind of, crosses my T's, dots my I's for me and helps me walk through the different things. Okay. So I've not done this yet. I'm just preparing for my patient. It's on there. I'm good to go. I've gone through my documents notes. I know kind of what's already in their history. I've transferred over what didn't automatically transfer, whatever I need. If there's anything that I'm like, I want to make certain I ask about certain things, I may even go in and put in a specific question that I want to make certain I ask that patient. And then I just go over the top of my question with whatever answer they give me. And it just helps me kind of keep myself straight, right? So I'm going to hit save and it's going to pop it into my notes here. Now, the other thing you're going to do is a safety plan in the event that they are having some suicidal ideation. If I see that there's some that even passive, I may do a safety plan anyway. So I'm going to go over here to my notes section. As you can see, I'm going to hit that little green arrow and I'm going to select safety plan. Okay. I know it's going to be today at 4 o'clock, so I'll change the time. Oh, I'm going to AM. Let me go the other direction. Okay, 4 p.m. Done. I don't really need a time. The diagnosis automatically, and this is going to be the first thing you're going to do is current coping skills. What do they already have under their belt? Remember, my sample patient is someone I've never seen before. They're coming in for their intake. So I'm going to, what kind of coping skills do you already have that we can utilize when you recognize that you're not feeling your best? So then you're going to say, and who are your safety people? Let's get some names. Let's put a phone number in. What are the different triggers that cause these things? And you sort of talk through a plan of what to do if this happens again. Okay. So I'm going to save that. So now it's preloaded in here, correct? So during the session, let's say I meet with them. I've gone through my intake. We've created a safety plan. And I don't necessarily need to do the safety plan if they're not suicidal, so keep that in mind. One of the things to note, let's say you load this in there because you're like, I want to make certain I have it ready and I don't want it gone. If the session's going on and you're like, oh, I never ended up needing it, you can just go up here and hit delete and just remove the safety plan. Now it's no longer in the notes, as you can see here. The only thing here now is that intake note, right? Okay, so the next thing you're going to want to do, and I have a list here. So we've done the safety assessment. We've done the safety plan. I'm now going to do the ABH IOP internal referral decision tree. It's a mouthful of a name. So I'm now going to open this up. And this is going to walk me through essentially the script for how to make a referral for IOP. And when I'm meeting with my patient, I'll pull this up, or I'll go through and I'll copy the parts I know for a fact I want to be able to say, and I'll create myself like a cheat sheet. Okay, so I've got here this IOP. What is IOP and how do we describe it to them? Did the client have a score of 7 or higher? Yes. Has the client been in outpatient services for at least 6 months with no significant marked improvement? Well, no, because they're brand new coming to me. Has your client had a 7 score or higher on the NCC distress thermometer for more than 2 consecutive sessions? No, it's the very first session. So technically, they don't qualify. However, as I stated before, they seem kind of borderline. So I'm like, I don't know. Let me keep reading. Let's see what it says. So I'm going to scroll down. Is your client uncooperative or uncompliant? Well, no, I don't know that. I've not met with them yet. No clue, right? IOP may not meet the minimum requirements for IOP. Absolutely, they may not. I don't know yet. Does the client treatment history or lack of treatment goal progress, or your clinical expertise suggest that outpatient therapy is ineffective and continuing this level of care will not provide symptoms relief and or significant change? So in my case, I'm going to say, you know what, maybe. I've not met with this client yet. I'm going to have to really think about this as I'm going through it. So this is one of those sentences I would probably copy and paste, and I would just need to review it at some point during my session. If the answer is yes, then proceed on the yes side. If the answer is no, proceed on the no side, and you don't need to make a recommendation. If your client diagnosed one of the following with at least moderate symptoms, and so all of them are listed essentially: bipolar, major depressive disorder, anxiety, chronic OCD, PTSD, disruptive mood, ODD, borderline, any version of that. And so if they've got those symptoms and it's escalated, okay, continue. Yes, an internal referral is required. If you're seeing all of these in there, yes, it is required. It is not required if the answer is no. But you need to go back to this question, your clinical expertise. What is your gut telling you that this patient needs, right? So then we go through, and here are the symptoms we're looking for. We're looking for at least 2 on the left and at least 2 on the right. So in my case, there is some passive SI. There's no plan, there's no means. They've got lots of reasons to live, but they keep having these thoughts of like, I wish I would just die, or I wish I wouldn't wake up this morning, or some version of that. And they are concerned about impulsivity. They have found that they're doing really strange things late at night. They're cutting their hair, they're dyeing it blue, they're whatever. And they're worried about that impulsivity. So on this side, I'm like, yes, they qualify. But over here, I'm not finding anything. There's no disinterest in maintaining relationships. They still have their friendships. There's no risk-taking behaviors technically, but they have this fear that they might. Concerns about client between sessions, not eating or drinking water, not taking prescribed meds. I mean, they're not doing any of these things. So technically, they don't qualify. This is where you would then have a conversation with that patient and say, okay, this is what's going on. I'm seeing these symptoms over here that have me concerned. But you're not meeting the requirements for some of these. We have a script over here. Based on your distress, I would recommend that we discuss more intensive counseling. That is a sentence I have used routinely when I'm making these referrals. IOP is a program that just helps give skills and patience to help guide things and start to feel overwhelming, and can help us give jumping off point for going deeper in sessions. It gets skill-based, and we get a lot more done in these intensive programs. It's a 6-week program developed to help lower distress levels in multiple areas. So down here at the bottom is a definition of what is IOP at Adjuvant. So if they have specific questions, you can ask. 6-week program. It meets, I believe, 3 days a week. I don't see that that's listed here. But then they would take a break from you while they're in IOP, and after IOP is over, they'd come back to you. In the meantime, you will stay in touch with their therapist and work through those things. So let's say, okay, the patient doesn't technically meet the threshold, but the patient wants it, and you believe it would be beneficial. So you're going to go ahead and make that referral. So how do we do that? The steps then are to IOP internal referral form. So this is a form within AMD. So in order to do that AMD, we're then going to, let's try and open up, trying to think, how do I have to do this from here? Okay, so notes. I'm going to do an internal referral form. In here, internal referral. Here we go. IOP internal referral. So it's a template, just like you would do any other note. I'm going to select that. I'm going to make certain their diagnosis is correct. I'm going to make certain that time of the session is set for the correct time. And you're usually doing this part after the session. You don't need to preload this or anything. Not that I have seen, unless you're just afraid you're going to forget. You go into the notes. Most of the stuff will preload based on your intake that you did and that treatment plan that you created. I think that's the part that makes this a little bit messy. Sometimes you need to create that treatment plan before you proceed. So you got this diagnosis, diagnostic reasoning, presenting problem, history of problem. Most of this preloads from the notes that you took. Who are the previous people that they met with. This is going to be something that you can get directly from their form if it doesn't autofill. Patient confirms. You're going to check to make certain that medications are correct. And this is listed. Dr. Fake gave me Mucinex and Allegra. I must have done this at some point. That's funny. Any history, physical health histories, or anything there that fills in, doesn't fill in. This may require some follow-up. So some of these are good reasons for why you might want to have this preloaded, because what you can do is you can go in here and be like, okay, what are the different things I need to ask you? So in which case, if I did it ahead of time, I could just hit save and it will. Again, you'll see it here. If I hit save, it pops it in here. So I'm already starting this process, and I can always, again, delete that form when I'm done. So if you'll feel more comfortable with loading this in ahead of time, go for it. Most of it will preload, but if not, once that's done, you're going to save and sign just like normal. Save and sign. Okay, so then the next form that our process says that we need to follow is we also need to do the message IOP internal referral. So after that's done, so now you have a treatment plan. So you have the intake, the treatment plan, you did the safety assessment, you did a safety plan, you then did the internal IOP referral form, and now you're going to message the internal process. What did we call this here? Message IOP internal referral. So this just lets the team on the administrative side know to go looking for this person and to start the process. So the way that you're going to do that is you go back to this dashboard. You're going to go to messages. You're going to select new message. And on here, you're going to go down here and you're going to select, let me think, IOP internal referral. And it pops them in over here. Do you see that? So IOP internal referral pops them over. I'm going to make certain that the proper patient is selected here in this form. I'm going to hit test. Put test Jenny. So this is where you're going to want to be careful and make certain that it finds the correct person. You should be able to do a drop down from here. See how now I can see everyone with the last name test. So I'm going to make sure I select me. And let's say I am, see if I can spell. Making a referral, please reach out to this patient, blah, 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 and then hit send. And that's it. This is essentially what's covered, what's ready. And what I love about preloading those notes, like I showed you here, is I have them already saved and ready for me to do, and I can always delete them if I don't use them. Let me do a stop share. So at any point you have questions, please reach out to me. Let me know. Send me a text message. Send me a chat. And then I can also share the processes with you. Be sure to check that ABH resource library in the process and procedures folder for SI protocol and reporting. And you can just follow the directions verbatim. I walk you through each step with directional arrows. Let me know if you have any questions. Bye.